Cystoscopy with retrograde pyelogram and ureteral stent placement, fluoroscopy, direct vision, and ultrasound confirmation. In this video, we provide a detailed examination of the procedure for cystoscopy with retrograde pyelogram and ureteral stent placement. We systematically compare the techniques of fluoroscopy with direct visualization and ultrasound confirmation. Our personal preference is to use a 30-degree lens and a 19 to 22 French cystoscope sheath. Hydrophilic wires are generally preferred, but they need to be kept moist for optimal performance. Straight wires are typically favored for routine use. However, if the anatomy is abnormal, tortuous, or unusual, an angled tip wire is likely to be more effective. The open-ended catheter is essential, and the most commonly used size for the double J stent is 6 French, 26 centimeters. The patient should be in the lithotomy position. To begin the procedure, gently advance the cystoscope through the urethra into the bladder. Apply gentle pressure to ensure smooth navigation, while avoiding any excessive force. The cystoscope is carefully maneuvered until it reaches the bladder, where it is positioned for optimal visualization. Once the cystoscope is inserted into the bladder, the guide wire can be advanced through the open-ended ureteral catheter into the ureteral orifice. It should be advanced until the floppy tip coils in the renal pelvis, as determined fluoroscopically. Advance the open-ended catheter slowly over the guide wire as the wire advances. Be careful when advancing an open-ended catheter up the ureter. A small amount of diluted contrast injected retrograde into the open-ended ureteral catheter is sufficient to visualize the renal pelvis. Advance the guide wire through the proximal coiled end of the stent, pushing it all the way through. Insert the stent into the cystoscope until the proximal end of the stent is visible in the distal ureter. Place the pusher over the guide wire and use it to advance the stent into the ureter and up to the renal pelvis. Finally, slightly retract the guide wire so that its tip is just below the curl of the proximal end of the stent. This will allow the soft, proximal end of the stent to curl up in the renal pelvis naturally. To safely remove the pusher, first advance the pusher in a few centimeters until the distal stent tip has been pushed out of the cystoscope sheath and the end of the stent is visible completely inside the bladder. Ultrasound confirmation during the placement of a double J ureteral stent is used in specific clinical situations, such as in pregnant patients, to reduce radiation exposure for both the physician and the patient, in patients with iodine contrast allergies, or even in cases where fluoroscopy equipment is not available. When choosing between fluoroscopy and ultrasound for double J catheter placement, consider the following. Fluoroscopy provides detailed, real-time imaging but involves radiation and often requires contrast agents. Ultrasound avoids radiation and contrast use, making it safer, but may offer less detailed images and depends on the operator's skill. Both fluoroscopy and ultrasound have their unique advantages and drawbacks in double J catheter placement. The decision on which method to use should be guided by the specific needs of the patient, the complexity of the case, and the available resources.